realised there is another consultation skills model that I wanted to share with you because I think this is pretty important. This is called the health belief model, and it looks at why do people attend for their condition, and why do they accept or don't accept treatment. So there are several sections to this. The first is to do with perceived susceptibility to the illness. How likely are they to get the illness? And this is really important for preventive medicine and for things like take-up of flu jabs, COVID vaccinations, that kind of thing. The next thing is the severity. What's the perceived severity? How bad does the person think it's going to be for them? The next is what's their perceived benefits. What do they think the treatments are going to be? What do they think they're going to be in terms of how good they're going to work? The next is the perceived barriers. How hard do they think it is to get some treatment, and what might go wrong with the treatment for them to decide not to use it? Then there's also something called the cue to action. What is it that made them book that appointment at that time? And then you can also look at the variables that led to this situation. So looking first at susceptibility, so this would be whether a person thinks they could develop that condition. So let's say an overweight person has never had their diabetic check done, and you suggest it and they don't want to have blood tests done. And it may be because they know that diabetes runs in families, and there's no one in his family with diabetes, and therefore he can't get it. Or a person who's never had the flu before, and therefore they don't need to get the flu jab because they don't get the flu. The next one is the perceived severity. So how bad is the condition going to be for them if untreated? So, for example, if it's untreated, will it kill them in the end? Could they end up in hospital? Or could it have some significant impact in their life, their ability to work or to do their hobbies, do the things they want to do? The next is the perceived benefits of treatment. Do they think there is a treatment that will help? And if so, will it work? How well will it work? And then the last one is this kind of section is the perceived barriers. So, for example, how hard is it to get an appointment with their doctor? How difficult would that be? They might need to get a taxi, and they might need half a day off work. What are the barriers to treatment? Can they afford the prescriptions? Can they get to physio appointments? What else might there be? Side effects of treatment, time taken to do the treatments. And then the last is acute action. So that would be what was the point that said, right, that person needed to come in. So it could be that a family member told them they should go in. So it's not unusual for a patient to come and say, my wife made this appointment for me. If someone says that, then there must have been some previous barrier to them coming in. They either felt it wasn't severe enough, there was no treatments that were going to be acceptable to them. So when you're discussing management plans, if the person says that at the start, then you're aware that they may not be too interested in the treatments you're going to offer. So understanding their health beliefs is going to be really important. Other things that might be acute to action, something happening on EastEnders about prostate cancer is likely to trigger several thousand men to go and get some tests done at their local GP. There may be an advertising campaign, that kind of thing. And then the last bit is about the variables. So what is it that led to that individual having those health beliefs? So that's going to be a combination of lots of factors. So things like their education, their culture, how old they are, their underlying personality will all contribute to decide on this health belief that that person has. So if we looked at example, let's say a 60-year-old man, he's had gradually worsening knee pain over 10 years. Now, up until recently, he's been working, he's the boss of a company, he hasn't had time to come in to the GP surgery, but actually he just sits around all day at work. It doesn't bother him too much. He tries to play golf some Sundays, it aches the next day, but he's not doing much for a few days anyway. He can't take time off to see a physiotherapist. Ibuprofen affects his stomach, so he doesn't want any painkillers. So there's no point in his mind coming to the doctor. He's now retired and he's trying to play golf 3 times a week. His knees flared up. He now can't play golf. He's had 2 weeks with no golf. He's no longer the boss of the company. He's sitting around, and this is suddenly, without actually much difference to his knee in the underlying pathology, has gone from not bothering him to a catastrophe, and he wants to be seen today and stuff done straight away. He's now able to come in to see you. He's able to get appointments for tests and treatments, and so he wants action immediately. The condition hasn't changed, but the cue was that change in his lifestyle. Now, the important thing to remember with this is you often don't get any of this information with the doctor-centered questions. So if I ask this man, how long has it been going on for? Does it swell? Which side does it hurt? What does it feel like? What have you taken for it? You're going to find out he's probably got knee osteoarthritis, but you won't find anything else about his health beliefs. This is all about the ideas, concerns, expectations, and asking why. So when you get an answer, always ask why. Why was that relevant? What do you mean by? Okay, I hope that makes sense. Worth remembering this one. Thanks.